Welcome to this OR Live webcast presentation on advances in breast health. Physicians and health experts from Bon Secours Health System will discuss the importance of detection, treatment, and management of breast disease. OR Live makes it easy for you to learn more. Just click the Request Information button on your webcast screen and open the door to informed medical care. OR Live, the vision of improving health.
Hello, I'm Carol Goldsmith with WYFF News 4 in Greenville, South Carolina. Today we're talking about new advances in breast health. And I have three women with me who are experts in the field. I'm going to let them introduce themselves right now. The first is Dr. Gail Thomas, who is a surgeon. Gail, tell us a little bit about yourself.
I'm the medical director of the Breast Health Center at St. Francis. I'm a cancer surgeon. I'm fellowship trained in surgical oncology, and I specialize in breast cancer. Also in the treatment of benign breast diseases.
All right. Kathy Koger is a registered nurse, and she is a breast health navigator, which is an intriguing title to have. Tell us about what you do, Kathy.
My job actually is to be with the patients after they have found out there's something wrong with their mammogram. I pick the patients up at that time and will follow them all the way through a joyful good news diagnosis or all the way through chemotherapy and beyond. So I'm there to walk with them and assist them in every facet of care that they receive.
Our third panel member is Dr. Julie Egger. Julie, tell us about yourself.
I'm a PhD nurse, and I'm actually faculty at Clemson University also. I am fellowship trained in genetics from the Nursing Institute at NIH, and have also gone to City of Hope and some other special classes so that I could learn more about genetics, especially as it relates to families who have a high risk for cancer.
So as you can see, we have a group of panelists here who can address just about every aspect of breast health. And let's start with our first topic, which is as women go through different stages of their lives, their breasts change as well. And let's talk about some of those changes. I think, first of all, when a woman feels a lump or a thickening in her breast, she automatically assumes the worst, which she shouldn't do, right?
Correct.
Dr. Thomas?
I mean, most breast changes or breast lumps are benign. And I think the most important thing that a woman can do is to get used to examining her breasts. And she should do that once a month, usually the week after her menstrual cycle. If she's not having a menstrual cycle, then pick a time of the month that's easy to remember, like the first of the month or another time of the month that say that she pays her bills or something that's easy for her to remember. And get to learn your own geography of your breasts. Learn those lumps and bumps that you find on your breast exam. If you find something new or different, then that's when you need to go see your doctor.
One thing that we've heard recently is that breast self-exams are not beneficial to women, and obviously you beg to differ on that.
Very much so. Every once in a while this comes out in the press that it doesn't have any impact on a woman's health, and I really disagree with that. I think women need to be responsible for their health. I think they need to do monthly breast self-exams because that's taking responsibility, and I think that's very important for women to still do that every single month.
What are some of the benign lumps that a woman might find in her breast?
Cysts, very, very common, and they can actually come and go, particularly in a premenopausal woman. Fibroadenomas,
which is?
They are benign, solid lumps, very common in women in their teens, 20s, 30s, and 40s. They are not a risk factor for cancer. They are solid lumps. Sometimes they can actually grow to be fairly large in size, but they are benign. Those are probably the two most common benign conditions.
So basically the message you're saying is if you find something, first of all, don't panic.
Don't panic. Okay. Don't panic.
Kathy, what about guidelines for when women should be examined?
Well, if a woman does find a lump, then they would need to go see their primary care physician, their OB doctor, their family family care physician, they would examine them at that time and then refer them on for what we call a diagnostic mammogram. That's a difference in their screening mammograms. We do recommend screening mammograms every year, starting at age 40. That's the current recommendation. But if they do find a lump, that's a different type of mammogram where they're going to come in and meet with the radiologist, and they would have their mammogram that day and also be able to speak with the radiologist and know that day if there is a problem or if they do not have a problem that they need to be concerned with that day.
Now that's a relief, because a lot of women are thinking, I go in for this thing and then I've got to sit around and wait and wait and wait. But what you're saying is with the diagnostic mammogram, you would find out right away.
Correct. And our radiologists actually have a term that they say, go in peace, if they're okay. So they do let the ladies know that day, and that's an important difference there, that if you are just going in for a screening, you're not going to know that day. You get a letter in about a week. But if there's a problem, all of us would be so nervous and tense and want to know right away, and we do let them know that day.
What can the woman get from actually meeting with her doctor and having a clinical exam? Some people would argue, why don't you just jump from going from breast self-exam right on to the mammogram? But there is that middle step where you see your doctor.
Right.
How do you get there?
Right. Well, they're going to get a clinical breast exam done by their physician at that time and get a chance to go over their history and any risk factors, those kind of things, and then they would be able to also get the patient in much quicker for a mammogram.
Dr. Eggert, we talked a little bit about the family history. You spent a lot of time concentrating on that. How important is the family history?
A family history obviously is very important if we're bringing it up to focus on. But when we think about family history, if indeed a woman has a family history, as far as screening is concerned, it can impact the time that she would begin her screening. Instead of 40, if the person in her family had had a diagnosis at 45 of breast cancer, then perhaps we would want to start her screening at 35. Family history is also important because it could mean that it's an inherited cancer. And so we'd want to look at additional guidelines, perhaps screening guidelines for those individuals. Another piece, through working with the women who have had a high risk of or a high incidence of cancer in their family, one thing that they frequently ask me, because they're frightened for their children, is about lumps that their boys and girls have when they're going into puberty. Just teeny tiny little breast lumps. And what we know is that when people begin to mature, they develop breast buds. And so this can be very, very normal changes that probably every child experiences. If you have a family history, it probably doesn't hurt to have it checked out, but it certainly isn't anything to be alarmed about.
Well, that brings up another question. When should people start with a clinical breast exam and with self-exams?
We would suggest that someone begins their breast self-exam when they turn 18. Sometimes we even suggest to younger girls that once they have breasts, it certainly is a good time to go ahead and begin learning how to do that. But again, with those breast buds, sometimes it's a little frightening because there are some changes that are just normally associated with developing breasts.
We do have some questions in from our audience, and I'd like to encourage them as well, if they have any questions, to make them available to us. But one of them that ties in with this topic is this idea of fibrocystic breast disease. And I know there's even controversy over whether or not to call this a disease, but talk a little bit about that. What are we talking about when somebody is fibrocystic?
I don't like the term disease because it sounds like there's something wrong with you. And it's really a pathology term. Breast tissue is made up of many components, and it's just referring to really what's seen on a breast biopsy. And a lot of ladies will come in and say, I have very lumpy breasts, very fibrocystic breasts, and it's just really normal breast tissue. It can be very lumpy, it can be very fibrous, and it's just a normal part of the breast tissue. It doesn't mean that there's anything wrong with the breast, and it doesn't mean that it's an increased risk for breast cancer. It's just normal breast tissue, really.
That said, a lot of women do complain about, you know, maybe cyclical pain along with the lumps and that sort of thing. Do we know anything about what can be done to help kind of ease that?
I think breast pain is one of the hardest things to deal with. And it's one of the most common complaints that I actually see in my office. It seems to come up most often in women probably late 30s to about early 50s. I don't really see women who are in their early 20s or postmenopausal women with breast pain. And I think it's really hormonally based. And it's really symptomatic relief. We make sure that there's nothing causing the pain, such as a cyst or an infection, and it's usually just breast pain. And it's symptomatic relief, sometimes non-steroidals, looking at the bras they're wearing. Sometimes the underwear bras can actually be cause of some very bad breast pain. But it's a lot of reassurance that there's nothing clinically wrong that's actually causing the pain, and it's actually a very normal part of their breast cycle.
There is a perception out there that women are being diagnosed with breast cancer earlier in life. Is that actually happening, or is this sort of a part of being able to diagnose tumors when they're smaller, perhaps?
Well, I think breast cancer is a disease of aging. The older you get, the more risk you are of having breast cancer. I think what we're seeing now is because our mammograms, our ultrasounds, our MRIs are so good compared to what they were 5, 10, 15 years ago, that we are picking up breast cancers at a much earlier stage than we were before. We're seeing tiny calcifications that we couldn't see 5 or 10 years ago, and our radiologist will even tell you that. So I think we are diagnosing breast cancer at an earlier age, particularly women in their 40s, that we may not pick up until 5 or 10 years down the road when they may have had a more symptomatic lump. So I think that we are seeing patients in their 40s with more breast cancer, but it still is a disease of aging.
Are we seeing survival rates increase then if you're picking it up earlier and earlier?
Yes, we are. We are seeing survival rates are improving with breast cancer.
Dr. Eggert, who's really at risk for breast cancer?
Well, anyone, as Dr. Thomas has said, anyone as they age becomes at higher risk. So basically we could say that there are two groups of people at risk to develop breast cancer. It can be sporadic, which we see in women who, as they age, they would be more likely to develop a sporadic breast cancer, meaning we don't really know the cause. Or there's inherited familial breast cancers. Women who have an inherited family history are more likely to develop cancer at a younger age. And when we say younger, I don't really like this age, but younger is less than 50. But in reality, what we see is they indeed are in their 30s and 40s. So in addition to what Dr. Thomas was talking about, I think that another point about earlier detection is that there's so much media attention to breast cancer, which is really a good thing, because I think that's another reason women are feeling more comfortable to go and have mammograms and see their physicians and talk about this, because the media is saying, yes, indeed, we are curing them and there is more hope than some people believed there was in the past.
Do you find a lot of stress with women who have perhaps a strong family history of breast disease?
Yes, a lot of stress, and that's one reason they come to me, is to talk about their family and history, and indeed what is their risk. And that's one thing that I always ask them, what risk do you think you have? Are you high risk? Do you think you're low risk, medium risk? And almost every single woman, no matter how many people in her family have had breast cancer, says high risk. And what we know is that if you have a mom or a sister, then there is perhaps a 50% likelihood. But if you have a great aunt or a grandmother or someone like that, really the risk is not as high. But it's always good to come, and like if they would come and talk with me, I can help them specifically identify what their risk to develop breast cancer is, and then also what is the risk that they actually carry one of the breast cancer genes.
And the risk can come through the father's side of the family as well?
Right. It's very interesting that men do develop breast cancer. It's incredibly rare, but if there's a family history, the men do not tend to develop it, but they carry the gene. And so I've had patients who have actually, a young woman in her 30s develops breast cancer. Her father didn't have breast cancer, but he was an only child. His father did not develop breast cancer, but he was an only child. And so what we found out was, indeed, the family, the cause of it was actually 3 generations out. And everyone thought that it was the mom's side because all these women had breast cancer, but they were in their 60s. And so we found, indeed, that the gene came from dad's side. So it is important to recognize that.
And talk about family history.
Exactly.
A lot of families don't.
Right. We always encourage people to do that, just generally, but encourage them to talk about it when everyone's together at a reunion. And we joke about, I'd be happy to go to any family reunion if they want to pay my way.
Our special guest today is.
But also when families gather in addition to reunions, like at Easter or Christmas or Thanksgiving or, you know, any other holiday where there is a group gathering and the family is there.
And the important point is, and I tell this with my patients, not everybody always thinks it's your mother's family history.
Right.
And that's very, very important, but always ask about your dad's family history. And I've seen a lot of patients where the breast cancer has come through the dad's side, not through the mom's side. So always ask not only about your mom's side, but your dad's family history.
Let's talk about when a lump or thickening or whatever is found in the breast. Are there new technologies, new options that women need to be aware of when they go in for an exam? Kathy, what do you think?
Well, the first one that they're going to have done is a mammogram. They'll have that done and then likely proceed to have an ultrasound done, a breast ultrasound. They'll have that done and they can determine a lot of times from that what the risk is or what they're looking at. One of our newest technologies is breast MRI, and we're seeing much more of those, and it's much better at detecting areas in women with very dense breasts, younger women, and those kind of things.
Do you get women saying, let's just jump ahead to the MRI?
Yes, yes. And the problem with that is a lot of times our insurance companies these days are not wanting to cover an MRI just because I'm scared and I want one. So we do have to have, there has to be a medical indication for it. Before that those are covered by insurance usually. It's a very, very, very useful tool, and we're using that a lot in appropriate cases, appropriate patients.
Digital mammograms, let's define that. What is it?
Well, at St. Francis Eastside at our breast center, that's all we have is digital mammography. It's a newer technology. It's much more specific. It's a tool that the radiologist can use to look at the breast films a lot more in depth, a lot more sensitive, a lot more specific. It helps to use a computer program to look at the actual breast tissue, and it uses about 25% less radiation. So we're very pleased that both of our mammogram machines now at St. Francis are digital. So I think that is the wave of the future now, is all going to be digital mammography. We also have state-of-the-art ultrasounds at St. Francis, and we have a breast MRI.
I heard a radiologist once describe looking for a tumor in a dense breast as looking for a snowball in a snowstorm. Have things improved where they can actually find a snowball?
The MRI helps a great deal in those cases particularly. It's a very useful tool.
And I think another point, what they've been describing typically is with a woman who has an identified problem. If you have a family history and you have a certain level of risk, it is a standard of care to order an MRI. And that didn't used to be the case unless you indeed had a physical problem that needed to be more carefully localized. And so that reinforces why you should know your family history, because then you would be able to have one of those ordered on an annual basis in addition to your mammogram.
It's intriguing how procedures have changed because, you know, some women who had problems maybe you know, 10, 20, 30 years ago, they would instantly go into surgery, they would have a biopsy. That's not necessarily the case now. There are other things that can be done. Needle biopsy, for example?
Right.
What happens with this?
Well, typically, if we do find an area that's suspicious, say you come in and have a mammogram and yes, there's a suspicious area there. You've had an ultrasound and that it remains suspicious and they recommend a biopsy. They do the ultrasound biopsy actually in radiology with the patient awake. It's about a 20 to 30 minute procedure, and then you have a diagnosis of either it's okay or it's cancer. It's either a benign problem or it's cancer, which helps Dr. Thomas out a great deal. And if it is a cancer, she knows prior to going to the operating room.
Mm-hmm. I've just been handed a question that kind of fits in with our discussion. Are tumor markers for breast cancer as dependable as genetic testing for detecting the probability of developing breast cancer?
There's not a really good tumor marker per se for breast cancer. I mean, you can't go out and have a blood test, and I'll let Julie deal with the BRCA testing, like for CEA for colon cancer, PSA for prostate cancer. So there's not a blood test that you can go have every 6 months to see if there's your breast cancer coming back or a recurrence. But I'll let Julie talk about the BRCA testing.
The BRCA testing just means that there's a gene, a BRCA gene that has had a change or a mutation. But the mutation does not mean that they will develop breast cancer. It just means that they have a higher risk. The research literature doesn't say that you absolutely will develop it, nor can you absolutely know that you can prevent it. But I have patient experiences or examples perhaps, who have been very careful about their diet and their exercise. All of their sisters developed breast cancer when they were 30, and these patients developed it when they were older. They were very upset that they still developed breast cancer, but yet when they reflected on the possibility that a good diet and exercise perhaps pushed it to a later age. And, you know, again, we don't know that all mutations are an indication that someone will develop breast cancer. It just means we need to screen more carefully on an annual basis. They need to see their healthcare providers for clinical breast exams and more careful follow-up. Mm-hmm. But, you know, as Dr. Thomas said, a specific tumor marker, those are really for after you know you have a breast cancer, and then you follow with that.
We've all heard of women who have had preventive mastectomies because they have the genes, they have a strong family history. Is that at all common among this group of women, or because of the improvements in detecting cancer, are they more willing to wait and see?
Well, for BRCA families, they have about an 80 to 90% chance of developing breast cancer. Mm-hmm. So those women usually do elect or have the option to have prophylactic mastectomies. Mm-hmm. And they also can have prophylactic removal of their ovaries. They have the option to do that electively, mm-hmm. To have their mastectomies and reconstruction at the same time. I think we are seeing more women having prophylactic mastectomies. Frequently, when they have breast cancer on one side, depending on the risk, they will have a prophylactic mastectomy on the other side. I'm seeing more and more patients doing that. So yeah, I think we are seeing an increased risk.
Mm-hmm. How effective is it to have that? I mean, it's a very radical thing to have done. Is it 100% effective?
There's never a 100% guarantee if you have a mastectomy that you're not going to have either a recurrence if you've had breast cancer, or if you're having it prophylactically, that it's 100%. The studies that have looked at BRCA families that have had prophylactic mastectomies have actually shown excellent results, that those patients have not gone on to develop breast cancer. But again, we've only known about the BRCA genes since the mid to late 90s, so we don't have great long-term follow-up, but the studies so far have been very good.
Let's talk about the good news and the advances in the treatment of breast cancer, because as we mentioned earlier, I think a lot of times when women hear that diagnosis, they just freeze and think, that's it. But there have been so many advances in the treatment of this disease. Let's talk a little bit about that. Julie?
Well, one thing I would like to say, and really Dr. Thomas can talk much more specifically about the treatment. But one thing with all of the new modalities that are available, because there's chemotherapy and radiation therapy and surgery and some of the targeted therapies, what I have seen with patients that I've worked with, that breast cancer is really becoming a chronic illness. It's not a death sentence. And I think when I explain it to patients, I talk more about how many friends, family members do you know that have diabetes? It's a chronic illness, and we focus more on what symptoms are happening and target that. And you know, we're not seeing it as well, as Dr. Thomas said earlier, we are seeing survival. And it's because of all of these new therapies and knowledge that we have to target exactly how that breast cancer is growing and why.
Mm-hmm. And there's so much support as well.
Mm-hmm.
For example, Kathy, what you do is
Right.
supportive to the patient, and you can answer a lot of questions right from the get-go.
Right. I usually meet with the patient prior to ever even having a biopsy. So I've usually met a patient twice before they ever get their diagnosis of breast cancer. I'm with the radiologist when they give them their diagnosis, and able to let them know that they're never alone, that I'm always there to walk with them throughout their whole journey. And that's just something that we feel is very important, to let every woman know that they're never ever alone, that there will always be someone that they can pick up the phone and very easily get to. And that's my function, is to try to minister to the whole person as a whole being, physical, spiritual, mm-hmm. mentally, with their family, financially, if they need assistance. We do a lot of just the whole being.
Mm-hmm. And there are physicians and other support people willing to talk about the specific breast cancer. Let's talk about the Tumor Board a little bit. Explain what that is.
St. Francis has a weekly breast tumor board that I chair, mm-hmm. and it's a very dynamic group. All the disciplines are present. We have radiologists, pathologists, Kathy's present, Julie is there, medical oncology, radiation oncology, nursing, plastic surgery shows up occasionally, rehab nurses, and we all talk about the patients. We talk about them at the time of diagnosis. We come up with a treatment plan, whether it be neoadjuvant chemotherapy, surgery, do they need any further testing as part of their workup. Then they go through their treatment plan, and if they've had surgery, we talk about them post-op and come up what sort of treatment they're going to have after surgery, whether it's further chemo, radiation, or whatever. And it's just a fabulous multidisciplinary team approach for the patient.
And it's fairly unique, right?
It's extremely unique. It's really the only one of its kind in the upstate to present to the patient their treatment plan.
Mm-hmm. So it's not a cookie cutter.
No, oh, no, absolutely not. No.
One thing I've seen that has been exciting to me is that even the primary care physicians or nurse practitioners have been coming to the tumor board, so that as their patients are discussed, they're able to come and hear about what's going to be happening to their patient that was referred to Dr. Thomas or another member of the medical staff at St. Francis. The other thing that I think is really exciting is that it's not just one time. They come back and it's discussed. And the other thing I like is, as you said, it's not a cookie cutter. Someone will say, well, I just read this article in a research journal and it said this. What do you think about that? What about trying this? Well, I disagree with that. Mm-hmm. And it's really, it's a friendly, what's the word I need to say? A friendly, not
dialogue,
friendly dialogue, friendly dissension, if you will. Mm-hmm. That not everyone is agreeing with this is the best approach. They're offering out different ideas. And then they come to a conclusion, and then Dr. Thomas calls the patient. And I think that is so excellent that there's that discussion with not just one discipline, but multiple disciplines, including nursing. I get patients referred to me, and it's really exciting, dynamic, and it's something that patients really are going to benefit from. Our community is benefiting from it.
Right, and it's like a second, third, fourth, fifth, sixth opinion free, and it's all presented all at one time, and the patients are told what the recommendation is.
Do you get a sense, a feeling from the patients how this works for them? Do you think it's an improvement from the patient's perspective?
Yes. Oh, they love it.
They do.
They really appreciate it, and they want to know what the tumor board said.
Right.
And every cancer patient that I treat, I present at Tumor Board. And I tell them that I'm going to be talking about them at Tumor Board. And so when they come back to me, you see, the next week, I sit down and I go over, we talked about you at Tumor Board, and this is what Tumor Board recommends. And they really appreciate knowing that every single one of those doctors and all the support personnel were there talking just about them and talking about their case and coming up with a treatment plan just for them. And that we're going to be talking about them through the whole journey of their treatment.
And what was interesting to me when I first heard about this is it's not always a cancerous tumor that you're talking about.
Correct.
There's some benign conditions you bring up as well?
True. We talk about benign cases. We talk about unusual cases. And anybody can bring a case to Tumor Board to present any of the disciplines. We can present unusual cases, patients we might be worried about. And it's an ongoing education for all of us in Tumor Board.
I've presented women who didn't need to have surgery for breast cancer. They just had a high risk. And they were interesting because they had a different type of high risk cancer, not a mutated gene that was a BRCA gene, but a different one that was a little bit more rare and unusual. I'd like to reinforce also, this tumor board is of the kind that you would see in places like MD Anderson or Dana-Farber or City of Hope, where there's more interaction and more vibrant discussion about what we should do for this patient. They talk about clinical trials. It really is an exciting time when the group gets together, and then you see everyone kind of clustering in little broccoli clusters, I've heard them say, afterwards saying, you know, that was a good point. And it just really is, you can see that it's developing the team for more stimulation and better patient care.
And it sounds like continuing education for the physicians and support people as well.
Right.
It really is.
Julie, tell us more about the Cancer Risk Screening Program, CRISP. What's that all about?
It is all about families who have a high risk of any type of cancer, really. What we focus on is breast and ovarian, because that fits with the breast center and what Dr. Thomas has been trying to provide to the community. People do not have to have a physician referral. They can self-refer. Radiology refers. Also, nurses can refer. But they come to me and we have a long, detailed discussion about their family history. We talk about aunts and uncles, people you've never really thought about before. I tell the patients that if they don't come to me with information, they'll be going home with homework. And so, but we talk about, as Dr. Thomas indicated earlier, both mom and dad's side of the family. With the people having divorce and remarriage and all of those things, sometimes it gets very complicated, but it's like being a detective. It's so interesting, and it helps the family learn that maybe someone that had a female problem, in reality it turned out to be a colon cancer instead of whatever that female problem was.
Yeah, because back in the day that was the euphemism for everything. You know, she had a female problem, and
or
that
pleurisy.
could have been.
That's what I remember. My grandmother, everything was pleurisy. So it really, I think, helps the family become more aware about what is going on. So we go over the history, and then we talk about what is it most likely that they would have a risk for. Would it be a BRCA1, a BRCA2? Meaning that would it be more likely to be premenopausal, more likely to be postmenopausal? And then we talk about if you were tested, what would you do about it? Because if you wouldn't do anything about it, perhaps you really don't need to be tested. It's expensive to be tested. What we're finding is that the insurance companies are more willing to pay for almost all of it now. And with the new GINA legislation, there's not a risk for, now I'm forgetting the word, for pre-existing conditions and discrimination.
That would have been my next question.
Yes.
If you do test positive,
Right.
do you suddenly lose your insurance?
Yeah, no longer. The insurance company is viewing it as valuable information that can help them use increased surveillance and screening and hopefully early detection if indeed that was something that would happen. A genetic test, that might be the next question also. What do you have to do to have a test? It takes 1 vial of blood, that's all, and we send it to a lab in Utah. There's only 1 lab in the world because they have the patent, and so they do the test and send the results back to me, and then we talk about what are the implications. And the implications could be surveillance, increased surveillance that we've talked about. It could be chemoprevention, it could be surgery, and then not only for the family, but I mean the individual, but for the family. Should anyone else be tested? Should anyone else have different screening? If it's not just a BRCA gene problem, if it's a different kind of gene, then perhaps we're going to need to do things like annual urinalysis because they might be at risk for other kinds of cancers. So it's not just about, do I have a gene for breast cancer? It's about learning more about your family, seeing if it's going to affect others in the family, and is it only going to be breast and ovarian, or are they going to be at risk for other types?
Well, let's back up and talk a little bit more about the risk posed by family history. Now, just because you don't have a family history doesn't put you in the clear either, but we've already mentioned that having a family history with some of the BRCA genes would put you in a high-risk category. So do we want to let people know that even if you don't have a family history, that doesn't mean you're in the all clear?
Right. In fact, women who have no family history, we have more women diagnosed every year that do not have a family history than women that do. And so, you know, it's a matter of just because you don't have a family history, you absolutely need a mammogram.
Well, I think a lot of women think that they're BRCAs or their hereditary family history, and that really only makes up about 7% of all the breast cancers. And most women with breast cancer are actually sporadic. They just happen. But the actual BRCA families actually make up a very small percentage of the breast cancers.
Do you encourage your patients as well to share the family history? I talked to a man who had prostate cancer. No one in the family ever knew that the grandfather had had it, and he made a point to let everybody know that the risk was there.
I do encourage them, but I guess the other piece of that is that individuals are different, and some people really don't want anyone to know. And we talk about if you have that gene, it perhaps, if you know you have it, it decreases your anxiety or increases your anxiety. So sometimes it doesn't necessarily mean that having the test done is going to decrease your anxiety. Sometimes it makes it increase. But yes, we do absolutely encourage them to tell everyone else. It's, you know, it could be that they could have the gene, and those individuals could be tested at a much lower rate also.
We have a number of questions from our audience, and they aren't in any particular order, but this one is about the Tumor Board. Is it unique to St. Francis, and can a cancer patient request her oncologist present her case to Tumor Board?
It's unique to St. Francis, and if her oncologist comes to the Tumor Board at St. Francis, I would assume that certainly she could have her case presented there. I've never had that question asked before, but I assume.
We have several oncologists that present. I coordinate it, so they call me and say they would like to present patient so-and-so, and that's how that works. So yes, they certainly could if they come to St. Francis.
The multidisciplinary piece and that active, dynamic, prospective, multi times is what makes St. Francis Tumor Board unique.
Mm-hmm.
Can you develop cancer while you're nursing?
Yes. You can develop cancer really at any time, at any age. It's unlikely because if you're nursing, you're younger. You're probably in your 20s or 30s. And the age of between 20 and 30, only about 2 to 3% of all breast cancers develop in that age range. So it's very unlikely. But again, do your breast exams. If you find anything abnormal, go see your doctor.
What age is at the most risk for breast cancer? Is there an age that is?
It's really a linear curve or a linear line, and as you get older, your risk increases. So most breast cancers are found in postmenopausal women, so age 50 and up. So it's each decade as you get older, your risk increases.
This question says, I'm adopted and don't know any family history. Are there any blood tests that can determine my risk of breast cancer?
And boy, that is a really
It's a hard one. It's
yes.
hard.
There really are no blood tests. I mean, you could have genetic testing, but the problem is the BRCA gene is a huge gene, and you really need to have someone who's had a diagnosis of cancer that we can figure out exactly where the mutation is along that gene, and then the second individual has it, and we can say, okay, here's that family mutation. And so if you're adopted, it's really difficult. And so what we suggest is careful surveillance and self-breast exam.
This questioner says, my nipples are getting darker. Is that bad?
I don't think a color change per se. It may be just a change of aging. But I think if there's any bleeding, any crusting, any actual change in the skin, any lumps, then that's certainly something that needs to be checked out.
Okay. Is it best to have reconstruction at the same time as the mastectomy?
That's a very difficult question to answer.
It sounds like an individual.
It's a very individual choice. Some that I spend hours sometimes speaking with patients about. It really sometimes that's a patient choice. If patients are going on to have chemotherapy and maybe chest wall radiation, sometimes they choose to have their reconstruction later. The important point to make is that doors never shut, that they can have reconstruction really at any time. Some ladies really choose to have it at the time of their mastectomy, and others choose to delay it. That's a conversation also to have with the plastic surgeon.
This is something we touched on earlier, but I think it bears repeating. When do I need to check my breasts each month? It probably depends on where you are in
your menstrual cycle. Really, the week after your menstrual cycle, things are the calmest. You're not as swollen, you're not as tender. That's the best time.
And postmenopausal, just pick a day.
Just pick a time. Just pick an arbitrary time.
All right. This questioner has implants. Can mammograms still detect cancer?
Implants make it very difficult to do a mammogram. You can still do a mammogram. The techs have a way of actually pushing the implant back and getting the breast tissue.
That sounds painful.
I'm sure it is. To actually getting a mammogram, it does make it more difficult. You can get a mammogram, but it just makes the whole process more difficult.
Would any of the other ways of examining be better, like an ultrasound or an MRI?
MRI. MRI is very good, and sometimes we do just send the ladies for an MRI.
What exactly is a lumpectomy?
A lumpectomy is where you actually take the lump out. You preserve the breast. A mastectomy is actually taking all of the breast tissue off. So lumpectomy is just making an excision over where the lump is, removing that lump, leaving the breast.
What do we know about the effectiveness of that versus a mastectomy? Or I'm assuming it depends on what the tumor is.
Right. If you look at all of the studies comparing a lumpectomy versus a mastectomy, stage for stage, for cancer. And a lumpectomy with radiation and comparing it with a mastectomy, survival rates are equal. So that's why we can now offer lumpectomies for conservative surgery if the patient and her doctor chooses, and if that's the best surgery for the patient, instead of a mastectomy.
Can you still nurse your baby if you have had breast cancer?
Yes.
What is the difference between chemotherapy and radiation therapy? Do you need both, or can you choose which you want? It sounds like a very individual question again.
It is. I think your team of physicians is going to make that decision. It's going to depend on the size of the tumor, the type, what the markers are. Someone asked that question earlier. On the tumor, it's going to depend how much is available to remove, and if for radiation, sometimes it's for local control, and chemotherapy is for more general systemic control, and there are different types of chemotherapy, and it works with different types of cancers, and sometimes you want to have the chemo first and then the surgery later, and it just depends.
Well, let's tease that apart a little bit, because I think a lot of people, they think of radiation, they think of being burned, of having it being extremely strong, of it being dangerous. They think of chemotherapy as being constantly sick, losing all of your hair. Have there been improvements made in those therapies as well?
I think people have a lot of misconceptions about chemotherapy and radiation. I think they think back to 20 or 30 years ago when people got extremely sick from both of them. I think we've made tremendous strides in both of those treatments. We have excellent drugs to help counteract a lot of the effects of chemotherapy, particularly nausea. Chemotherapy is through your vein. It's treating the entire body. Radiation therapy is local therapy, so it's getting radiation to that breast area. If you have conservative treatment, meaning a lumpectomy, usually you will have radiation to your breast. Chemotherapy really depends on your pathology. Whether you have a lumpectomy or a mastectomy doesn't really matter in choosing your chemotherapy. That's really a discussion with the medical oncologist and looking at all your pathology results.
We're almost out of time, but before we end, I'd like to hear from each of you a way to wrap up and let people know what your primary message is today about breast health. Let's start with you, Dr. Thomas.
I think patients need to know that breast cancer is very treatable. Do your breast self-exams, get your mammograms every single year. If you find anything of concern, go see your doctor immediately. I also want to say another thing about our breast tumor board and how dynamic and how great I think it is. And I think it's a wonderful service, providing an excellent standard of care for our patients at St. Francis.
Nurse Koger?
I think that one thing I'd like to just wrap up in saying is that at St. Francis you always have someone that's available to you. At the pickup of a phone, you can call a Never Alone. We're always there for you and always there to help in any way that we can.
Dr. Eckert?
Well, I'm never very good at only saying one thing, so I want to say two if I can. Obviously, I want to say how important I think that it is to know your family history. But the other thing is, and I guess perhaps this is part of that multidisciplinary tumor board, but it's not just one day a week. The team is there and wants to be a part of your care, the patient care, the family care. And to me, that's a real important point, that it's not just one day a week, it's every day a week.
Thank you all very much, Dr. Gail Thomas, Kathy Koger, nurse and Dr. Julie Eggert. Thank you so much for joining us. We want to remind everyone that Vive, the magazine for stronger women, is available, and in this particular issue, they talk about breast health at each stage in a woman's life, from the 20s, 30s, 40s, into the 50s and beyond, the things that a woman needs to be aware of and needs to do in those particular decades. Lots of great information available inside this magazine. I'm Carol Goldsmith with WIFF News 4. Thanks for joining us today.
Thank you for watching this OR Live webcast presentation on advances in breast health. with physicians and health experts from Bon Secours Health System. OR Live makes it easy for you to learn more. Just click the Request Information button on your webcast screen and open the door to informed medical care. OR Live, the vision of improving health.